what do men over the age of 40 need to know as it relates to prostate care. I need you to help the audience understand the basics and what is actually happening to men across the lifespan as it relates to prostate care, and walk me through what's happening with that man who is getting up 3 times a night. What does that actually mean?
Well, maybe we'll step back a little bit. The prostate is a gland, as you know. I think a lot of men, believe it or not, may not really realize the functionality of it, but it's a hormonally induced gland. It's an endocrine, part of the endocrine gland system. So it is affected by testosterone and male hormones. And as men age, there are changes in the milieu of the hormonal environment, and the prostate can enlarge. Benign prostatic hypertrophy, BPH, as it's referred to, is one of the things that can affect men as they get older. And it's sort of, the bladder is like a balloon. It turns into the urethra, and the urethra actually goes right through the prostate. So if there's any growth of the prostate, benign growth, let's say, that can kind of impinge upon almost like a tunnel, kind of getting narrower and narrower, and that can affect the urine flow. And when that happens, men may need to, again, maybe get up at night to urinate, go more frequently during the day. Medications can help with it. There's different procedures that can help with it. But in general, most men, if they are having urinary symptoms, end up seeing a urologist. Urologist ends up being almost like a primary care physician for men over 50, let's say. And it's always a good idea to get those things checked when they do start to change.
So walk me through. So the prostate is a gland. It's responsible. Which hormones are getting secreted from the prostate?
Well, the prostate is more a receiver of hormones. So hormones can activate the prostate. The function of the prostate is to make the seminal fluid. Mm-hmm. So the prostate is they say the average size is like the shape of a walnut, but that's about a 25-gram prostate. Most men, as they get older, have an enlarged prostate, and it can start to, we like to use fruit for some reason as analogies. So the size of a plum, sometimes even a grapefruit. We have men that have prostates that are 5, 6, 7 times the normal size. As you can imagine, the plumbing, as it goes through the prostate, can be affected, and that can affect urination. The seminal vesicles are glands, like rabbit-eared glands, that kind of root into the prostate, and they also provide some of the seminal fluid. Sperm is made in the testicles, and so during ejaculation, the sperm mixes in with the fluid from the prostate and the seminal vesicles, and that's what is semen, and that's what is ejaculated. So that's what the function of the prostate is. It's solely to produce a component of the semen.
It's interesting because as I was researching this podcast, I realized that prostate size doesn't really correlate to cancer risk, which is something that I've heard of.
Right.
You can have a man with a massive, benign, enlarged prostate and another man with a small prostate harboring aggressive cancer.
Yeah, that's true.
Can you explain this paradox?
Listen, it only takes one cell, for all cancers. And as a radiation oncologist, I treat all types of cancers. So it really only takes one cell to go awry. In many of the glandular cells in the body, so whether it be thyroid or breast in women, men also can get breast cancer, but particularly with regard to today's talk of prostate cancer, one cell going awry, becoming a malignant cell, that's really all it takes. And so during a lifetime of constant hormonal manipulation, triggering activation, deactivation, those cells can have undergo changes. Some of these changes are proliferative. They can be like pre-malignant cancers, high-grade prostatic intraepithelial neoplasia. These are some of the terminologies that the pathologist will use. But in general, it isn't, as you say, related to size. Now, PSA, which I'm sure we'll talk about, which is the blood test that's quite important for screening and for cancer detection today, is actually related to size.
The world of oncology is still a mystery to me, and I know we've got good cancer screening tests, especially as it relates to prostate cancer, which I believe, and I don't know if you can answer this, do you think that it's odd to see people dying of prostate cancer just due to the amount of screening that's available to us right now?
Listen, for any kind of cancer, early detection makes a big difference. If we catch cancers earlier, they're easier to cure, and there's less potential for metastases, and ultimately there's less potential for patients to succumb, to die of their disease. In particular, PSA is prostate-specific antigen. It's a protein that's secreted normally by the prostate. Prostate cancer cells also secrete PSA. And as a man ages, the PSA can get a little bit elevated just from normal, as we talked about, enlargement of the gland. But if there's a cancer brewing in the prostate, then the PSA can be elevated. And so, typically, and there's a little bit of a debate about PSA and screening and over screening. But in general, it's an easy test to do. It's a blood test. It costs a few dollars, and it saves lives.
All right, so let's move on now to some treatment options.
Well, in general, men that have high-risk cancer need treatment. Men who have intermediate risk cancer tend to need treatment. Men that have low-risk cancer, there are options for possibly monitoring their cancers, especially when they have what we would even call very low risk prostate cancer. So just like intermediate risk is broken up into subcategories, we tend to break up low risk prostate cancer into subcategories. We look at a lot more information on the pathology report that we haven't talked about yet, like whether there's perineural invasion, whether there's extracapsular extension. These are like nuances of how the cancer may be behaving. But in general, if we don't see any of those poor prognostic pathologic factors, and somebody just is found to have one or two cores, let's say, of Gleason 6, so, and this is a typical man that we see, minding their own business, no symptoms whatsoever. They just get a blood test for their annual checkup, and the PSA is up a little bit. Again, they go to the urologist, they have an MRI, maybe there's a small lesion, they have a biopsy, and we find one or two cores of Gleason 6, low-risk prostate cancer. The next step in terms of talking to them about active surveillance is how aggressive or non-aggressive do they want to be with their treatment. The way that I look at active surveillance is that if the entire picture looks like the train hasn't left the station yet or isn't leaving anytime soon, men can choose to keep an eye on the cancer. What does that mean? We're not saying go home and never come back. They have cancer. It's a diagnosis. What we're saying is your cancer right now, there's nothing that's immediately life-threatening to you as the man being diagnosed, and we can continue to monitor you in the months and years to come and collect more data about your prostate, about the cancer. And if we do find something that tilts the scale, maybe the train's beginning to leave, then we can divert you to treatment. And the studies seem to indicate that when a man is appropriately diverted back to treatment, that their cure rate should be equivalent then to what their cure rate would be now. And so they don't compromise their medical outcome by waiting or pushing off their treatment. And the benefit of pushing off one's treatment is that you're not exposing yourself to the potential risks of prostate cancer therapy.
Can you live without your prostate?
Of course.
Removing the prostate, is that an option?
So removing the prostate that's a radical prostatectomy.
These words are so cool.
Well, it gets even cooler because today the radical prostatectomy is done robotically. So it's an RALP or a...
We're doing that at Lennox. We're doing some robotic surgery. It's phenomenal.
The robot, the Da Vinci robot, I think there's another company that makes another robot now, but I think the radical prostatectomy, the robot was the first real procedure that was indicated for robotic-assisted use. So today the typical radical prostatectomy is done robot-assisted. So the surgeon is sitting over here, operating the robot, and the patient has the trocars in the body that the robot is doing. And what they can do is they can get very, very accurate, the detail that's needed to dissect out the prostate, because remember, the prostate is sitting between the bladder and the rectum, as we showed before. So in general, the prostate has to be separated from the bladder, so the bladder neck is severed, and the urethra at the other end of the prostate is severed, and then the prostate has to be dissected out, and then the urethra reconnected back to the bladder neck. The nerves that control erections are lateral and need to be carefully dissected as well. So typically, unless a man has a more aggressive cancer, they are going to be having a nerve-sparing radical prostatectomy, where there's an attempt to spare the nerves. and improve erectile function.
You know, I'd be remiss if I didn't bring up the topic of testosterone in this. So I remember a patient case that I've had where he's undergone chemotherapy and testosterone levels plummeted, like completely. I think he was 52 years old. He had like 150 for his testosterone levels. What's the relationship between prostate cancer and testosterone levels?
Testosterone doesn't cause prostate cancer, but men who have prostate cancer, the testosterone can almost fuel the prostate cancer because, again, through a man's life, testosterone as an androgen, a male hormone, is constantly activating and deactivating the prostate as one of its targets. Prostate cancer can also be activated or deactivated by testosterone. So interestingly, in high-risk prostate cancer, we will often want to lower the testosterone in a man by giving him androgen suppression therapy. And what that will do is it will almost crimp the fuel line to the cancer and weaken the cancer. That weakening allows the cancer to become more susceptible to radiation. So we tend to offer or recommend androgen suppression therapy, actually lowering a man's testosterone in order to weaken the cancer. When we climb into the boxing ring with radiation, we're fighting a weaker opponent. And so most of the studies that have looked at the use of hormone therapy, we call it hormone therapy, really it's anti-hormone therapy as we lower someone's testosterone. The studies have shown that, randomized studies, that men who have high-risk cancer, who have hormone therapy before radiation and then during radiation, they live longer, they have a better outcome than men who just receive the radiation alone. So testosterone plays an important role, not in creating prostate cancer, but in men with prostate cancer, we can actually utilize that to improve their outcomes.